Okay, so first of all, thank you very much for asking me to come to talk to the nurses today. I have to admit to knowing very little about triage nurses until I started working with CareDoc in Carlow, and since I started, I'm just in awe at the speed that the triage nurses can draw information from patients, not to mention the level of detail that they're also able to get as well. So I've learned so much since I joined CareDoc, and I've probably also wrecked the mental health of a lot of my colleagues working there by asking them different questions. So this is me during the summer. The minute the restrictions lifted, we took off and went for 99s, and obviously we did take off the mask before hammering into the ice cream when we did finally get out. So as well as working with CareDoc, I work as a locum pharmacist with community and hospital pharmacy around the southeast. I teach pharmacy technicians here in IT Carlow, and I'm also currently a council member of the Pharmaceutical Society of Ireland, so I'm involved with regulation of the profession for my sins. I have about a year left, and then I'm finished with it. I can go off then and do what I like, in theory anyway. So you kind of wonder, sometimes people ask, what's a pharmacist doing in CareDoc? It's primarily a GP organisation, plus as well to the team of triage nurses and clinical nurses that we have working across the organisation. So the first thing is that it's good governance to have a mix of different skills at the table when we're developing multidisciplinary team and the different services that we can offer. So it's good for patient care, medication management, you know, where things are supposed to be stored or how expiry dates and so on are managed. And it's very interesting to see the difference in approach to medication between nurses, pharmacists and doctors across the organisation. I help with prescribing, prescription care queries, monitor things like the antibiotic policy, the drugs formulae, and I suppose it's the different skill set that I bring to the multidisciplinary team is kind of why I'm there as well too. There are days I'd say there's people on the team would like to put me out the door, but I'm surviving for the main part. So I kind of think a lot of times with triage nurses, one of the questions I hear them asking is around medication. When you contact a patient or you're discussing things with the patient, it's what medicines are they on? And it's about being aware of, apart from the regular medication, which people think of as prescriptions, some people don't think of the likes of an oral contraceptive pill as medication. So they don't tell you about that, or they don't tell you about the over-the-counter medicines they're buying, or the herbal medicines that they're buying. And obviously very few of them are going to tell you about the legal or illegal drugs that they might be taking. You know, there's a lot of people out there that are smoking dope at the weekend or taking yolks or whatever it might be. So you need to be mindful that the symptoms that they're presenting with could be due to side effects, different interactions, maybe allergic reactions, you know. So when you're teasing it out, medication has to be kind of there in the mix as well too. And I suppose the other thing you've got people doing is buying medicines online, and the ones that they buy online have no quality control, so there could be anything in them. And one of the things that kind of caught a lot of pharmacists that I know on the hop over the last 6 months is the amount of customers who landed into their pharmacies who hadn't been buying cholesterol medicines or blood pressure medicines from them for years, because they've been able to tip over to Gran Canaria for the summer and order their medicines. And now suddenly they're stuck in Ireland, so they've had to admit to their community pharmacist that they've been buying their medicines away. So there's a lot of medicines out there that are not necessarily recorded in the patient medication record or in the patient history. So it is something that triage nurses have to take into account when they're talking to their patients. And I think it's really important that patients need to know what kind of medication they're taking. I mean, there's so many interaction risks. Things like methotrexate, warfarin and clarithromycin interact with everything. Then you've got contraindications. Aspirin during pregnancy would be a big one that would jump out. Or you've got patients at risk of double dosing, where if they don't tell you that they're on Vimova, which contains naproxen or esomeprazole, and they present to you with a sore back, diclofenac a lot of times is the first drug of choice that people will give for aches and pains. Or if they have an upset stomach, they get lansoprazole. So you need to watch out for double dosing as well too. And of course, then you've got records not updated. With everything that's going on at the moment, GPs aren't issuing prescriptions as often as they should be. People aren't necessarily going to their local GP or the local pharmacy. And the other thing that you need to know is what's worked and what hasn't. And obviously, you're going to get all this done in the 30 seconds or 6 minutes that you have to talk to your patients when they're on file. So one of the things that we've been looking at as pharmacists, and I've kind of anybody I know that is dealing with medicines or any of the nurses that I work with, is to try and get people to think about the No Check Ask campaign. It's a campaign that was set up by the WHO, and the HSE have signed up to it as well. And it's about getting people who are on medication to keep an up-to-date list of their medicines, either at home or, you know, stuck under the phone or in their handbag or in their pockets or whatever. Because that way, if they're asked questions or they have to go off in an ambulance or whatever goes on, they have their medication with them, you know. And it's to get people to think about bringing those lists with them to all their medical and dental appointments, and getting them to think about, you know, making sure their carers have them, their sons or their daughters have them, you know. And if they're not confident in making the list themselves, that they talk to their local pharmacist or the GP about making a list. And one of the things that I suggest, if they don't feel like making a list, is taking a photograph of their medicines before they come in to see the GP. So that might be something you might have time to do on the phone, is just to take a photograph of the box of tablets, and at least then they can show it to the GP, and you can spot, you know, you mightn't identify everything that's in the picture, but just spot the high risk ones like methotrexate or clarithromycin is also very useful. And as I said, as soon as you start talking to your patients, I am conscious that the clock starts ticking and you only have a certain amount of time. So you can only do what you can do when you're talking to people about medicines during a consultation. But it's about thinking about, you know, if you talk to your family member, you know, whether it's an aunt or a mother or whatever, they'll tell their friends, and the word will kind of spread out in a ripple effect. And the more people we can get thinking about what medication they take, knowing the names of them and knowing possible interactions and why it's important, it can be very useful. So these were just two of the posters that were made for the No Check Ask. The patient one was before you take it. Know your medicines, keep a list, check you're using it the right way, and ask your healthcare professional if you're unsure. And then for nurses, doctors and pharmacists, it was before you give it, and it's the usual one: right patient, right medicine, right route, right dose and right time. But the big one that I think is really important is ask your patient if they understand. And that's something that sometimes we do forget about, particularly if it's regular medicines that were given to people. So that's just a taste of the WHO No Check Ask. The information is available both on the HSE website, on the ICGP website, and there's a safermeds.ie, which is the contribution that Ireland has made to the No Check Ask medication project. And this then is a look at the medicines checklist. Now, there's a lot of information on it, and it can be a little bit complicated. So maybe, you know, if you're talking to family members or you're talking to people about using it, it might be worth, you know, typing up a simple one. The most important thing is that it's kept as up to date as possible. So some of the GPs around Carlow, I notice now, are typing out a list every time the patient goes in to see them, and it's part of their My Life plan. Or My Health plan is what they get. So they get a list of the information, what it's for and how to take it. And it's not written with the one TDS, one QDS that a doctor would write on a prescription. It's actually written in clear language that the patients can understand. So you probably guess this is your usual patient who phones looking for help in terms of medication. He's run out of his regular tablets, he's no prescription, he has a medical card, he doesn't have a medical card, he has a hospital prescription, or he's run out of the little blue ones. And this is probably the most common thing you get when you're asking people about their medicines is, you know, what tablets are you taking, and they're on little blue ones or they're on little white ones or for blood pressure or whatever. And the thing is that if you're on little blue ones that look like warfarin, it's fine because warfarin is written on it. But if you're on any of these ones here, there's blue ones at the top, Pfizer, there's ones down the corner, the blister pack, and then loose ones. It's not so easy. I mean, they're only the blue ones I can think of. So I don't know if any of you can recognise the little blue tablets just by having a look at them. Just in case, I've put the names in for you. So the first one is Lanoxin PG. The next one is Valium 10 milligram, or the Roach 10, very popular with the boys to keep them nice and calm during COVID. Bottom one is Neoclaritin, and then over here on the left is the legendary little blue tablets that are known as Viagra. So you can see just by saying they're on little blue tablets, it doesn't really narrow it down for you. And you can imagine if they said, patient says, I'm on little white ones, that would be 100 times worse. So it's about teasing out the information from your customers, or your patients, I should say, not customers, and getting what they know about their medicines and then working it out yourself. So one of the things that has changed because of good old COVID-19 is that the legislation around the supply of medications with or without prescription has changed, and that has made life a lot easier. The introduction of health mail has allowed GPs to email prescriptions to pharmacists, and it's also allowed nurse prescribers to do the same thing. And the advantage of that, I suppose, is that the patient doesn't have to call in for the prescription, and there's no need to use the medical card prescription or actually sign it, which is very handy. You're also not struggling to read doctor's handwriting, and they've also removed the requirement for handwriting on controlled drug prescriptions. So the days of having to write the quantity required of controlled drug prescriptions in words and figures has been lifted thanks to the introduction of health mail. The thing that's really important to remember is that health mail is the only system that can be used to email prescriptions. Okay, you can't send an email prescription from a Gmail account or Hotmail or whatever it is you're using, because that's not considered secure. And the most important thing around these emailed prescriptions via health mail is that they're immediately traceable back to the prescriber, which is why you don't need the handwriting or the signature on the prescription anymore. The other thing then that's changed, which has made a huge difference as well for patients, is that they've increased the validity for S1A and S1B drugs such as salbutamol inhaler, Augmentin or blood pressure tablets or whatever, from 6 months to 9 months if the pharmacist thinks it's safe to do. So for anybody who might have got a prescription in March that is expiring in September, they've now got an extra 3 months on top of it. And again, that's taken the pressure off of the pharmacists, off the doctors, and off of any of the nurses who might be writing prescriptions. So it's good to know that if you're talking to somebody, you know, and they're trying to get you to get a GP to write a prescription, check the date the prescription has been written. If it's written within the last 9 months, they can use that prescription to get more medication. So that's useful to know as well too. Now, bear in mind as well that they haven't changed the validity for the CD2 and CD3 drugs. They're still only valid for a maximum of 14 days from the date the prescription was written. And if it's written to be dispensed in installments, the patient has only got 2 months to get all of those installments in the local pharmacy. The CD4 drugs are the Z drugs, Zimavane, Zolpidem, those kind of ones can only be repeated if specified by the prescriber, but the validity of those prescriptions has been extended slightly as well too. The other thing that's changed, you probably all remember the emergency supply of medicines legislation, where if a patient doesn't have a prescription, you can send them down to the pharmacy and the pharmacist can dispense them a supply without a prescription at the request of the patient, or a prescriber can phone up the pharmacy and ask the pharmacist to supply. So they've changed that legislation slightly and made it a bit easier for pharmacists to give the patients a decent amount of medication. So now a doctor or a nurse prescriber can contact a pharmacist, tell them what medication they need for the patient, and they can then supply the original prescription within 72 hours. And they can either do that by dropping the prescription into the pharmacy, sending it through health mail, or putting it into the post. And the prescriber can now request 5 days supply of CD2, 3 or 4 drugs if the pharmacist will supply, which is a huge thing, because up to this it was actually an offence for pharmacists to supply controlled drugs without a prescription, and it generally involved a fitness to practice hearing if the pharmacist did so. So that's made a big difference, particularly for palliative care patients. So for any nurses that are going into patient care to look after them, it makes it much easier for them to get what they might need to keep their patient comfortable over the weekend. They can also request the emergency supply of midazolam, clobazam or clonazepam for the treatment of epilepsy, which is a change to the previous legislation where phenobarbital was the only medication that can be required. And any of you that may be looking after patients with epilepsy will know phenobarbital is very rarely used these days. It seems to have gone out of favour, and people are working towards midazolam, which would be the buccal, for example. So it's good to know that you can give an emergency supply of those. So you could send a patient down and ring the pharmacy yourself if need be. In the past, when a patient came in and they'd no prescription, the pharmacist could only give 5 days supply. Since COVID-19 came along, they can give 10 days supply of all S1A and S1B medicinal products if they've been prescribed to the patient on a previous occasion. So that's made a huge difference, because you can imagine a lot of people presenting with respiratory symptoms, coughs and colds or whatever, haven't been able to get in to see their GP. So they can phone up their pharmacy and get a supply of an antibiotic that might have been prescribed to them in the past. They can also now get 5-day supply of their CD2, CD3 or CD4 drugs if they can't get to a prescription. So it's good for sleeping tablets. But again, it is something that the pharmacist can only do if he or she can make a decision that in their professional judgment, this is what the patient needs. And then the other thing they can get is 10-day supply of the epileptic medication. So it's good for you to know if your patients that you're talking to don't have prescriptions, that there are ways for them to get their prescription-only medicines without actually having to get into a doctor or get a prescription issued to them. I suppose the big thing really would be the out-of-hours patients and palliative care, because, you know, there was such a palaver trying to get prescriptions or control drug supplies for patients in that situation, because the pharmacist needed the control drug, needed to develop prescription. So you had to phone an out-of-hours surgery or phone the triage nurses, explain what you wanted, get a doctor who didn't know a patient to write a prescription, collect the prescription, sort out the medicine. So this way it takes the pressure off the families, the patients and anybody who's caring for them as well too. I suppose the problem with this, and you may find it comes up if you've got medical card patients, is if they don't have a medical card prescription, they do have to pay the full cost. And that was where the reluctance for medical card patients to get the prescriptions or to go into the pharmacy and just collect the medicines has become a big issue. If you have a medical card prescription, or if you have a medical card, you pay $150 per item to a maximum of 15 per family if you're over 70. If you're under if you're under 70, it's €2 per item to a max of 20 per family per month. And the pharmacist only claims payment for these items if they have an actual prescription. So that would be why you'll find your medical card patients will come in to get the prescription. Otherwise, they're paying the full amount. You can imagine there's a big difference. But in that situation, you should be able to get your GP to email out, or your nurse prescriber email out a prescription to the pharmacy. If people are coming from hospitals or hospices and they don't have a medical card, those prescriptions can be dispensed in any pharmacy. So you will sometimes get calls from patients who are on their way home from hospital and they don't know how to get their prescription. So they just go into the local pharmacy, and that includes all hospitals and all hospices. Up to COVID, it was only the public hospitals. So the private hospitals like the Bonds, the Whitfield, Even couldn't do that. Now they can go into all the pharmacy, any pharmacy they want, and get the prescriptions medicined or dispensed. And the medical card patients can get a month's supply done on those prescriptions and only have to pay the medical card fees. Up to COVID-19, they could only get a week's supply, and then they had to bring their hospital prescription back to their GP or back to their nurse prescriber to have them written. So that's made life a little bit easier. So hopefully it'll take the pressure off of you when you've got patients ringing looking for prescriptions and so on. And the last little bit of information I have is just around medication queries from and to pharmacies. A lot of people are concerned that it can be a GDPR issue. So I went off and double checked it with the Data Protection Office and with the Irish Pharmacy Union and the Pharmaceutical Society. So any medication queries from a pharmacy to a triage nurse, or from a triage nurse to a pharmacy, is covered as part of the patient privacy policy. And queries can be made when a genuine issue arises that could affect the care received by the patient. So there's a tacit understanding between the patients and their carers that if they hand in a prescription to be dispensed, or they make a medication query to a triage nurse, they're giving permission for that to be discussed between the pharmacist and the nurse if needed, because the information is being used for medical treatment purposes. So in that situation, GDPR is not an issue. The other thing to be aware of as well too is that prescriptions can still be faxed and be compliant with GDPR, provided they're being faxed into a fax machine in the pharmacy dispensary and not one that's out on the shop floor as well too. So it's good to kind of know that as well. So there's some of the references I have if anybody wants to go off and look them up. They're all on the HSE website or the Pharmaceutical Society website. And if you do have any questions, I'm happy to answer them here now, but my email is there on the screen as well too. So feel free to send me an email if there's anything I can do to help. And that is it for me, unless anyone has any burning questions. So thank you very much for taking time out of your busy day to listen to me.